My talk is on mitral valve assessment for cardiac surgeons and interventionists. This is a long topic, but time is limited, so I'll go a little faster. Please bear with me. I start with a case scenario. An old lady presented to our hospital with the complaints of shortness of breath, hemoptysis, palpitation, and one query patient gave history of rheumatic fever. Her pulse was 100 beats per minute, BP was 100 by 60, first and second heart sounds were of variable intensity. There was a pancystotic murmur as well as a mid-diastolic murmur, and bilateral basal crackus was present. ECG revealed that atrial fibrillation with fast ventricular rate, incomplete RBP, and right axis deviation. ECG showed cardiomegaly with LV type apex, double right heart border, widening of the carina, and straightening of the left heart border. Here, Barristan along his view on echo showing that both AML and PML thicken, particularly the tips are thickened, there is reduced opening, caudal thickening, and enlarged LA. Shortest view showing that both commissures fuse and orifice is reduced and it is elliptical in shape. Here we planipulated the area and we found the area is 0.89 centimeters square, which corresponds to the severe image according to all guidelines. So color flow imaging showing the MR is more than moderate. Apical fourth chamber view showing the stenotic flow as well as the regurgitant jet. The spectral Doppler showing the mean gradient is 14 millimeter mercury, which is supporting that it's the case of severe MS. From the TR PPG, we see that the PPG is 63 millimeter mercury, supporting that the patient has pulmonary hypertension. So we measured the annulus, we measured the tricuspid annular systolic excursion as a marker of RV function, and we summarized the echo report that it is a case of chronic rheumatic heart disease with severe MS and moderate severe MR, dilated LA, moderate CR and PH, hypertrophied RV with moderate to severe RV systolic dysfunction, and good LV systolic function. So what are the parameters we have to evaluate by echocardiography when to evaluate a case of mitral valve disease? We need to consider anatomy, etiology of the valve disease, determination of the severity, indication of stress exercise, and to determine the timing of intervention and who should intervene, cardiac surgeon or intervention cardiologist. So I start with mitral stenosis. Normal MV orifice area is 4 to 6 centimeters square and symptoms do not usually occur until orifice area is less than 1.5 centimeters square. So etiology of mitral stenosis mainly acquired, and a few cases we may encounter congenital. Among the acquired rheumatic heart disease, the predominant, and I will focus on the rheumatic heart disease. Among the congenital, we encountered in our echo lab supravalve mitral ring and parachute mitral valve. So I will only highlight these two cases. So regarding rheumatic pathology, there is commissural fusion, and because of commissural fusion, valve domes in diastole, we can see that in the short axis view, both the commissurals are fused, and there is a leaflet thickening. Sometimes there is fibrosis thickening in short hair of the chordae, and calcification may also progressively involve chordae. So according to the 2008 AAC guideline, the severity of mitral stenosis is considered with less than 1 centimeter square and supporting feature mean gradient more than 10 millimeter mercury and pulmonary artery pressure 50 millimeter mercury. Still, this guideline classification severity is popular in our country, and according to the AACC 2020 guideline, valve area where less than 1.5 is considered severe and pressure after more than 150 millimeter considered severe. At risk of MS, that is stage A, there is only valve dome during diastole and there is no other hemodynamic consequences. Progressive MS is usually the mild to moderate MS, and severe MS, two group, asymptomatic with absence of symptom, asymptomatic presence of symptom, and the criteria, the other criteria are the same as I have summarized in the previous guideline. So when stress echocardiography is indicated to unmarked symptoms when mitral valve area is less than 1.5 centimeter square and no or doubtful complaints. When there is a discrepancy between resting Doppler and clinical findings with exercise or abdominal stress echo, if mean pressure gradient rises more than 15 millimeter mercury and PSP more than 60 millimeter mercury, then it is a time of intervention, and depending on the valve morphology, if it's suitable, then the patient may be referred for PTMC. So for PTMC, how to predict the outcome of PTMC, most widely scored is the Wilkins score. This score considers the leaflet mobility and thickening of anterior leaflet, caudal involvement and calcification, and rate from 1 to 4. So the total score range from 4 to 16. But there is some limitation of Wilkins score. It does not consider the commissural calcification and does not consider the concomitant other valve disease. So in general, patient with a score of less than 8 to 9 with no commissural calcification and less than moderate MR have the best outcomes from PTMC. So there are contributions for PTMC when mitral valve area is more than 1.5 centimeter square, absence of commissural effusion, LA thrombus, more than mild mitral regurgitation, severe or bicommissural calcification, severe concomitant other valve disease, and or concomitant coronary artery disease requiring bypass surgery. So here we show that we see that appendage thrombus and LA thrombus contraindication for PTMC. Here we can see the commissural calcification as well as calcification within the valve orifice, which are the contraindication for PTMC. So transesophageal echocardiography is important to rule out LA appendage thrombus before PTMC, and it also guides transeptal puncture for positioning of the balloon during PTMC. 3D echo has higher accuracy than 2D echo. Here is an echo view of a patient suitable for PTMC. Personal long-cis view showing the pulse are pliable, there is moderate subvalvular involvement, and color imaging reveal only mild MR and mild AR. So short shows commissural effusion, and we can see the appendage is clear. There is no LA or LA appendage thrombus. So this patient can be referred for PTMC. Apical force review confirming that the MR is only mild, and spectral Doppler shows that the mean gradient is suggesting severe MS. So pliable leaflet with minimal subvalvular lesion, the reconstruction is feasible, but if there is severe subvalvular lesion, probably reconstruction not feasible. Rigid leaflets with minimal subvalvular lesion, probably reconstruction feasible, but extensive subvalvular involvement, reconstruction not feasible. So, which mitral stenosis should be referred to cardiac surgeons? All hemodynamically significant rheumatic MS with contraindication for PTMC and all congenital MS which are hemodynamically significant should refer for cardiac surgeon. Here, example of supravalve mitral membrane. This patient should refer to cardiac surgeon. And here is an example of parachute mitral valve, a congenital case. We can see that thickened leaflets attached to a single papillary muscle by chordae, and papillary muscle is close to apex. So this is the case should be referred to cardiac surgeon. Now we proceed for mitral regurgitation. So according to the AHA ACC 2020 guideline, when the clinical parameter considered for intervention in MR is severity of the valve disease symptom, that is severe symptomatic mitral regurgitation cases and asymptomatic MR with LV systolic dysfunction or increased LV and systolic dimension more than 40 millimeter, and if there is progressive increase in LV size, then this patient should be referred for intervention. So the role of imaging echocardiography is to determine the severity of MR, to determine the etiology of the disease. TT is recommended as the first-line imaging modality. Transesophageal echocardiography is advocated when TE is transthoracic is of non-diagnostic value. 3DT or TT is reasonable to provide information in patients with complex mitral valve lesion. Transesophageal echocardiography is recommended in the operating room when a mitral valve surgery is performed. So the 2D echo parameters we have to evaluate it for a case of MR, valve morphology and etiology, size of MV annulus, LA and LV dimension, RV size, LV systolic function, and regional non-motion abnormality of LV and RV. Doppler assessment for MR severity, emergent area and its nature, measurement of vena contracta, volumetric method for calculation of mitral regurgitant volume, PISA method for calculation of effective regurgitant orifice area, MR regurgitant volume, MR regurgitant fraction, as well as measurement of PA pressure. So here is an example of tracing the emergent area. Emergent area and the LA area should be, the ratio of emergent area and the LA area should be calculated. And when the ratio is equal to more than 40%, then it is considered as severe MR. Here, the measurement of vena contracta. Vena contracta is the narrowest portion of emergent downstream from the orifice, and it is the most practical method for measurement of MR severity because it does not affected by eccentricity of the MR. And when vena contracta is less than 3 mm, it is considered as mild. More than 7 mm is considered as severe MR. Here, quantitative calculation of MR severity. When regurgitant volume is equal to more than 60 ml, it is considered severe. Regurgitant fraction equal to more than 50%, or regurgitant orifice area equal to more than 0.40 centimeters square is considered as a case of severe MS. Additional essential criteria: the LA and LV should be enlarged. So the simplified approach, when we say that the MR flow appears to be more than mild, we should measure the vena contracta. If it is more than 7 mm, it's considered severe. Less than 3, mild MR. In between, we see the jet duration. For central jet, PISA should be applied. For eccentric jet, pulse Doppler method for measurement of regurgitant volume and regurgitant orifice area. Here, the stages of primary MR according to the AAC 2020 guideline. Stage A at risk of MR, stage B progressive, would consider mild to moderate MR, asymptomatic severe MR, and symptomatic severe MR. All the criteria I have already summarized, so I am not going through detail of it. So, what are the parameters we should use for day-to-day clinical practice? Jet area, vena contracta width, left ventricular end-diastolic and insisted dimension. Stress echocardiography is indicated for immediate risk stratification and to guide the timing of valve surgery. There is another parameter which is gaining importance for the timing of intervention. This normal ejection fraction, if LV global longitudinal strain is reduced, this patient should be considered for intervention. So here the detailed recommendation for timing of intervention in case of chronic primary MR, I have already summarized, so I am not going through detail. So for classification of mitral regurgitation, it depends on the valve morphology and depends on the mechanism of MR. When valve is morphologically abnormal, it is considered primary MR. It may be congenital, degenerative, rheumatic, toxic, or post-endocarditis, and it may be secondary when the cause is ischemia or other non-ischemic causes. Depending on the mechanism of MR, that is a leaflet motion, there is Carpenter's classification, classifying MR into type 1 with normal leaflet motion. There may be annular dilatation and perforation. Type 2, excessive leaflet motion. There may be prolapse or flail. And type 3, restricted leaflet motion, thickening infusion that may occur in case of pneumatic or LV or LA dilatation resulting from dilated cardiomyopathy or other causes. So the pre-surgical ecoevolution of MV, there is 2-type classification for assessment of MV, hemodynamic classification for assessment of indication of surgery, Carpenter's functional classification for embolization for assessment of valve repair. Mitral valve repair is the recommended treatment for degenerative MV disease. Calcification of MV annulus often makes the repair more challenging and can lead to complication, and it is best to avoid patient with to repair for a patient with a calcific valve. For repair, segmented analysis of mitral valve disease is important, and the valve is divided into 8 segments using the scallop of the PML as a reference, 3 scallop of PML, 3 segments of AML, 2 commissures of the valve, anterolateral and posteromedial commissure. Here are the standard echocardiography views for mitral valve scallops. So the goal of mitral valve repair is to re-establish anatomically normal mitral geometry, dimension, and function. Requirement for normally functional MV, fully mobile leaflets. The free edges of the two leaflets are well positioned, 5 to 10 mm below the plane of surface. It is the large surface of coaptation. The echo measurement that is useful for the surgeon to reconstruct the mitral valve, ratio of anteroposterior dimension of the annulus and the height of the anterior leaflet, which is normally less than 1.3. Height of the A2 is a good indicator of the size of the ring to be selected. Using the triangularistic longitudinal view by TEE, the number, shape, and position of the papillae muscles are assessed. Here, the parasternal longitudinal view showing how we measure the P2 length, how we measure the coaptation length or coaptation height, and the coaptation depth. Post-MV repair, the length of coaptation should be 4 to 10 mm deep. If it is less than 4 mm, further correction should be performed. If more than 10 mm, the patient may be at increased risk of developing systolic anterior motion of the mitral valve. So these parameters should be checked during operation by TEE, transesophageal echocardiography. So here, the probability of successful MV repair in organic MR based on the echo findings. When MR is caused by degenerative valve disease and this prolapse is localized, there is minimal or no calcification and mild to moderate annular dilatation, repair is feasible. In case of Barlow and rheumatic disease, extensive prolapse with localized or annular calcification and moderate annular dilatation, repair is difficult. In case of severe Barlow, endocarditis, rheumatic and secondary causes of MR, when there is extensive prolapse, extensive valvular involvement, then repair is unlikely. Feasibility of repair is unlikely. So here is a still picture showing the prolapse of AML. Emerged directed by the prolapse of AML, this case, and here the parasternal longitudinal view showing the prolapse of flail PML. Here emerged caused by the flail PML with torn chording, the eccentric emerged along the IS and the swelling within the whole LA. Flail PML is if half of the PML is involved, this case is suitable for repair. Here apical four-chamber view showing the flail PML with torn chording. The 3D view showing the prolapse of P2 segment of PML. This is a case suitable for repair. The TE and 3D transesophageal view showing that there is flail PML and there is a severe MR assessed by PISA. 3D echo of a true cleft in the mitral valve. Here 3D echo showing the direction of the cleft is towards the aorta. This helps the surgeon to repair the valve. Here is a parasternal longitudinal view showing the vegetation attached to the anterior surface of AML. So in case of endocarditis, this patient should not consider for valve repair. Here, vegetation causing perforation and emergent is passing through the perforation. We can see the loop of the in short axis view, clearly seeing the vegetation and the emergent passing through the perforation. Fourth chamber view showing the vegetation and the perforation and the emergent through the perforation. Here, example of some mitral valve tumors. On the upper left, we can see the myxoma. On the upper right, there is the papillary fibroelastoma attached to the chording. On the lower left, there is mitral valve, mitral blood cyst. So all these cases can cause MR, and the way that referred to the surgeon should depend on the clinical condition of the patient. So what is the take-home message? Mitral stenosis should be referred to the intervention for PTMC when the patient with pliable ML without severe subvalvular involvement, no commissural calcification, and less than moderate MR. And hemodynamically, all significant rheumatic MS patient not suitable for PTMC, and all significant congenital and other MS patients should be referred to surgeons. OMC, reconstruction, or valve replacement will be depending according to the valve morphology and associated condition. So Transcatheter edge-to-edge repair will be considered for patients with MR in case of severe symptomatic patient where surgical risk is high, mitral valve anatomy is favorable for the repair procedure, and patient life expectancy is at least 1 year. And mitral regurgitation to cardiac surgeons, all other MR cases were clinically recommended for surgery should be referred to cardiac surgeons with a repair or replacement that to be decided by the surgeon depending on the mitral valve anatomy. So finally, we have to decide that our treatment strategy for the case we have showed that old lady had more than severe MS, and more than severe MR. She was asymptomatic and she had good LV systolic function but reduced RV systolic function. So she should be referred for cardiac surgery for valve replacement. So thank you all for your kind attention.
Thank you very much, ma'am. I hope you can hear us.
Yes, I can hear you.
Yes, for an excellent talk, and I really appreciate you finishing on time. Now, we would like to have a 3-4 minute interaction with you. We have 2 mics in the center row, and anybody who wants to ask a question is welcome to go there. I would start the session of Q&A. Would you like to comment
Did I stop sharing?
Can you hear me now?
Yes, I can hear. Should I stop sharing?
Yes, now you can stop sharing, and we are now going to have a Q&A session. My first question before anybody else is that how would you go in a mixed valvular case where there is 2+ aortic regurgitation and mitral stenosis? How it is going to affect the quantifying the severity of mitral stenosis, and how would you recommend the patient for PTMC or surgery? Please, ma'am.
I think my Satish Prashar will elaborate about this topic for mixed valve lesion. But as you asked to me, that when there is a mixed valvular lesion, especially in case of aortic regurgitation, MS is underestimated. But depending on the other feature, that in case of MR, only isolated MS, LV is not so much enlarged. But when there is more than moderate, 2+ means the moderate MR. So there will be certain enlargement of the MR, certain enlargement of the LV. And so more than moderate MR and mitral valve morphology, if suitable for PTMC, we refer the patient to the cardiac surgeon. In that case, OMC with aortic valve replacement would be the ideal condition, the ideal suggestion.
And just one more thing. We have seen cases where there is more of a commissural calcification. Yes. So how would you send them for PTMC? Would you do something else to clarify the situation?
No. In case of commissural calcification, I have already mentioned, if there is severe commissural calcification and bicommissural calcification, this is absolutely a contraindication for PTMC. So this patient should go to cardiac surgeon for valve replacement.
Please, from the panel or from the audience, if you want to ask any question. Dr. Aishi, please.
In patients who have atrial fibrillation, and you are doing the continuous wave Doppler, just for our understanding, how many complexes would you evaluate before you say that this is a tight mitral stenosis?
We have to evaluate at least 5 complexes, and the average of the 5 bit we will take. And as I have mentioned, that considering all the other factors, not only the Doppler criteria, the planimetry and the ideal and the gold standards and associated feature, the LA enlargement. So considering all these factors and taking the average of 5 bit, we will consider whether the MS is severe or not.
How close is the planimetry correlation with the continuous wave Doppler? And when would you trust planimetry?
Planimetry, which we trust most, because continuous wave Doppler, it depends on the hemodynamic condition, if AF with first ventricular rate, then a continuous expected Doppler parameter is not reliable, and especially when the patient presented with AF with first ventricular rate, we recommend the patient to come again. So after controlling the heart rate, we assess the patient again.
Just a last question. We are
Yes.
talking about global longitudinal strain these days of the left
Yes.
ventricle. Are you doing the left atrial strain also in these patients to see what happens to the left atrium after surgery? And what would be the result of on the ejection fraction in patients who have a mixed valvular lesion, who have mitral regurgitation? The ejection fraction, would that improve or would that reduce after surgery?
Not the fixed criteria, but sometimes after mitral valve surgery, when there is no caudal sparing surgery, we find that the left ventricular systolic function is reduced. But if the surgeon do caudal sparing surgery, we find the cases there when LV function is preserved. And to predict the postoperative LV dysfunction, if there is preoperative GLS reduction, then it indicates that the improvement of LV function after surgery. Even the preoperative EF is preserved but GLS reduced, this indicates there is presence of subclinical dysfunction. So this patient should go for surgery.